Good morning, and I would like to thank Dr. Jayakrishnan and his team for inviting me to Trivandrum, and it's nice to be here amongst my old friends. This is about CTG, and I was just talking to Professor Piley about whether you all use CTG, and he said yes, it's frequently used, so it might be quite easy for me to go through. Now, CTG is actually cardiotocograph. So cardiac is actually the heart rate which is recorded on the paper, and toco is the contraction which is recorded on the lower half. And when we talk about the heart rate, we talk about the baseline rate, which is calculated by ignoring all the accelerations and drawing a straight line and reading it off a scale. And baseline variability is the wriggliness you see here. And if you take any 1 centimeter segment and draw a line on the uppermost and the lowermost, that bandwidth is called the baseline variability. Accelerations are abrupt rise from the baseline and coming back abruptly back to the baseline. And usually it should be more than 15 seconds, and the amplitude should be more than 15 beats. And that is, if there are 2 such accelerations, we call it a reactive trace. And decelerations are just the opposite of these accelerations, and that means there is some stress to the baby. Now, although we call it cardiotocograph, the features really represent the central nervous system of the baby. These accelerations are really due to somatic nervous system activity. Whenever the baby moves, there is an acceleration, or if there's a motor or a submotor cortical activity, then there is a acceleration. Suppose if the baby is sleeping or has had pethidine or infected, then there won't be any accelerations. Similarly, the baseline variability represents the other part of the brain. The sympathetic system pushes the heart rate up and the parasympathetic pushes it down, and that means the autonomic nervous system is working well. So although we look at the heart rate, we are really looking at the somatic and the autonomic nervous system in some format. And the decelerations, if there are variable, those are due to cord compression. Late decelerations are due to reduced placental reserve, and so forth. And normally they should come with the contractions, and if you don't see any decelerations in a trace, then probably if the trace is abnormal or pathological, it's not hypoxic, it might have some other etiology. Now, we must always remember CTG is a test, like doing a full blood count. So you have to really take into the context of the clinical scenario, but about the parity, the progress of labor, and the risk factors. Because if it's a pathological CTG at 9 centimeter in a multiparous woman, you may not do anything. If she is 3 centimeter in a primigravid, you might want to do something. So reactivity is a term coined by Hon and Paul, saying the baby is reacting to the fetal movement with an acceleration. Now, a number of people use a mnemonic called Dr. C. Bravado to define these features, define risk, contractions, baseline rate, variability, and so forth. And then they had to classify based on the features they see whether it's normal, suspicious, or pathological. Suspicious means there are no accelerations, and there is a problem with some decelerations. Pathological, usually there are 2 abnormal features or late decelerations. And important to identify the pathology and to see whether we can reverse the issue by cord compression, altering the position, overstimulation, you stop the oxytocin, and so forth. Now, this is just to show that if there are accelerations, then not a single baby is acidotic, as you could see here. This is the original work by Richard Beard. On the other hand, if there are decelerations and tachycardia, 55% are acidotic, but this is a function of time. With more and more deceleration, more babies are likely to get acidotic. Now, the second feature which you see on the trace is what we call cyclicity. So first is reactivity, second is cyclicity. The baby has an active epoch followed by a quiet epoch, then an active epoch, and a quiet epoch. That means the baby's central nervous system is mature and the baby is not brain damaged. Suppose if the baby had CMV infection or toxoplasmosis or hypoxia before and then recovered, you might get these sporadic accelerations, but you may not, this active quiet epoch won't be there. So it will be some haphazard accelerations might be there. So in the beginning of the trace, you must establish their reactivity and cyclicity. Both are present to say this baby is not only hypoxic, but the brain is not damaged if you see the cyclicity. Now this is just a composite picture about each individual feature of the CTG is classified as reassuring, non-reassuring, or abnormal. This is for the baseline rate, baseline variability. If it is 5 to 25 beats, it's normal, that is greater than 5. But if it is less than 5, we say more than 40 minutes, we call it non-reassuring, up to 90 minutes. If it is more than 90 minutes, we call it abnormal. So it is also quite important the deceleration should be repetitive. That means at least for more than 50% of the contractions, we must see these decelerations. If it is simple variable over a 90-minute period, and if it is atypical or late over a 30-minute period. And then you classify, as I mentioned, normal, suspicious, pathological. One of the features of the heart rate is when there is a stress and there is a cord compression, as you could see here with hypoxia, gradually there is a catecholamine surge and the heart rate will start going higher and higher because of the catecholamine surge. In addition, the depth and the duration of the decelerations get worse and the time interval between decelerations becomes less. And generally, if the duration of the deceleration is much greater than the time at the baseline, that baby will get hypoxic. It is like immersing somebody under water for a longer time, keeping the person above water for a shorter time, then the chance of acidosis becomes greater. So in observing the trace, you must look for a rise in the baseline rate, increase in the depth and the duration, and so forth. Now, based on that, we call it as typical variable deceleration. So if you get a contraction here, if you draw a line at the beginning of the contraction and the end of the contraction vertically, if that falls within those two lines, it is called a normal typical variable. But if any abnormal features happens outside these two lines, at the beginning and the end, they are called atypical variables. Say, for example, in the same baby, there might be IUGR, that means the placenta might be small, and oligohydramnios. So the oligohydramnios will cause variable decelerations, and the reduced placental size will cause the late deceleration, bringing about a combined of biphasic deceleration. And if you merge it together, it will be late recovery. And similarly, the depth and the duration is over 60, it's not a good thing, and we will recognize a pathological or abnormal CTG. It is not only identifying and interpreting the CTG which is important. This confidential inquiry found that people fail to incorporate the clinical picture, whether there's meconium, whether there's IUGR, infection, bleeding, because those will increase the rate of acidosis. Third is actually, even after finding the CTG is pathological, if you don't take action in proper time, then the baby will be born in a poor condition. And most of the time it's poor communication which leads to the poor outcome. So the difficulties that lead to errors, there are a number of things: poor recording, not acting in time. So I'm going to go through 4 different patterns which is recognized, because if it is acute hypoxia, it presents with a prolonged deceleration or prolonged bradycardia. And here the baby will have a drop of the pH by 0.01 every minute, so the baby has to be delivered in about 20-30 minutes. Whereas subacute or prolonged decelerations comes back to the baseline, but for a very short time, for 30 seconds, but the deceleration lasts for about 90 seconds to 2 minutes. And here the pH will drop by 0.01 every 2 to 3 minutes. So the baby has to be delivered by 45 minutes to 1 hour. Now these are very common in the second stage and when there is some acute incidents. Now gradually developing hypoxia, the deceleration goes on for a very long time with the features I mentioned: rise in the baseline rate, reduction in the variability, and increase in the depth and duration. Now some babies, unfortunately, at the beginning of labor itself, they might have hypoxia and acidosis, and they present with no accelerations, markedly reduced baseline variability, and shallow deceleration. So I'm going to rapidly show you how the patterns look like. Now this is actually not early, these are variable decelerations as you could see here, and I just want you to see the baseline. So it generally says inability to interpret the trace, because these are precipitous fall and rise, the deceleration change in size and shape So these are variable, not early. The baseline here is 140 with acceleration. So although there is a stress to the baby by cord compression, this baby is not hypoxic at this moment because the accelerations are present and the variability is present. So this is at 19 hours. 20 hours, the baseline has gone up to 155. They are put on the side and given some oxygen. And 9 o'clock, they are given some epidural and IV fluids, and still at 155. They've done a field blood sampling, which seems to be okay. That's at around about 10 o'clock. And 11 o'clock, they saw her, there's no much change. Midnight, they forgot to see her. At 1 o'clock, the heart rate has gone to nearly 170. Now, this is a bad trace because not only the heart rate has gone from 140 to 170, but also the variability is getting reduced. And once the variability is reduced like that, like a pencil line, then within 60 minutes the babies will get acidotic. 15 to 20% will show acidosis within 1 hour. So this is at 1 o'clock, and as you could see, the depth and duration is getting worse, and they didn't do anything at 2 o'clock. If they would have delivered the baby here, the baby would have been acidotic, but they could have recovered that baby. But they didn't do anything, and 3 o'clock the baby gives up, and finally at 3:40 they did a forceps, but it is a stillbirth. So you can see that is a gradually developing hypoxia, and in America they call it Horn stepladder pattern to death. It takes a long time for that to happen. Now the one baby which is already hypoxic has no accelerations, markedly reduced variability, and shallow decelerations because the central nervous system is blunted, so it can't respond so well. And you can see the shallow decelerations, no accelerations, and hardly any variability. If the baby is in a quiet epoch or a quiet sleep phase, by 60 minutes or 90 minutes it should get up. So this is at 17:30. At 19:30, 2 hours later, there is no change. That means there is some problem going on with the baby. And if you don't do anything, every contraction here is going to cut off the blood supply, and there won't be any change in the CTG, but the baby will get more and more acidotic, and suddenly the baby will collapse. And so this is what is happening here. At 22:30, no change, hardly any variability, past midnight, and at 1:30, suddenly the baby goes down because it is severe metabolic acidosis. The baby is born here, it's a stillbirth. So one has to recognize, and these type of babies usually have a telltale signs clinically, like bleeding, infection, meconium, absent fetal movements, and so forth. Now the third variety is the acute hypoxia, when the heart rate drops dramatically and it is below 80 beats per minute. Then the circulation through the placenta, say if it is 140, is 1,400 times, but if it is 80, it's only 800 times. So in 10 minutes, it'll miss 600 beats, and there the pH drop is 0.01. And the 50% of the cases, the pH will drop by 0.01. And also the cause of the bradycardia is important, because if there is abruption or scar rupture, the blood supply to the placenta is also affected. So the baby will run into difficulty. So here is a case of previous section. Suddenly the scar must have given way at 1420, the heart rate drops. They've tried to change into ultrasound and ECG, and by the time they come to a conclusion, it is 1455. 35 minutes are gone, and obviously the baby has expelled out of the uterine cavity into the abdominal cavity, and the baby's condition is very poor. So this has to be picked up clinically as well. The fourth variety is the subacute, where the decelerations last for a longer time with a period, very short duration at the baseline. And this is not that uncommon in the second stage, and one has to really keep an eye on it, or with cord prolapse or scar rupture you can get it. And this is how it will look like. It becomes, you can see the deceleration is lasting for nearly 3 minutes. It's only there for 30 seconds. So you are immersing this baby underwater, 30 seconds, immerse again. This baby is going to get hypoxic, and this I'm going to show in 10-minute segment. This is 10 minutes later, and if it is a saltatory variability, that means over 25, that suggests the baby's autonomic nervous system is struggling, and that is indicative of hypoxia. So by this time, about 5 points of pH would have dropped, and here 10 points of pH, here 15 points, and here 30 points. So the pH started at 725, it will be 695 by this time. And something should be done, because it is not going to pick up. And here you can say this will be about 690, and once the baby is delivered at 112, as predicted, the baby's pH is 6.8 and the base excess is minus 19. So in subacute hypoxia, by 30 to 45 minutes, you have to deliver that particular baby. Now, another problem with the fetal heart rate, is it normal or not? We have to think about the physiology, and this is a misrecognition of the maternal heart rate. She is 41 weeks and 5 days, and you can see the heart rate is not properly recorded. It's 150. They say vaginal examination fully dilated, no contractions recorded, and suddenly the heart rate of 150 becomes 120, and once she starts pushing, with the contraction, the heart rate is going up in parallel with the contraction. So if you draw a line vertically here and another one there, heart rate is going up. Physiologically, when the head comes down and when she is pushing, there should be deceleration, not an acceleration. The maternal heart rate accelerates because the blood is pumped into the maternal circulation, and she delivers about 35 minutes later, and the ABGAs are poor, and they were saying, why did it become poor? Because there were accelerations, but they were recording the maternal heart rate. And this can happen suddenly in a trace. As you could see, there are a number of decelerations. At this point here, the heart rate must have dropped for the baby. The machine is picking up the maternal heart rate and showing acceleration. So in the second stage, if you see accelerations, then you might be recording the mother and not the baby. The other issue with fetal heart rate monitoring is, if you are using oxytocin, the uterus becomes more and more sensitive as the cervix dilates. So although you haven't touched the oxytocin, as the late first stage and second stage contractions become more and more, and when the fetal heart rate drops, sometimes the machine doubles it up. If it is on a fetal ultrasound mode, if it is 75, it shows it as 150. So there is 75 here and 150 here, and that is due to hypercontractility. And the doctor thought this was fetus is the mother, but this is really the fetus doubling as 150. So if you get two heart rates, then you have to be a little bit careful. You might be recording the fetus with a bradycardia, and this was the outcome in that particular baby. So two heart rates in the second stage especially is not a good thing. And here you can say it is decelerating, and because it is becoming hypercontractile, because the uterus becomes more sensitive, it is showing bradycardia and trying to recover, but it is not doing well. So it's important to reduce the dose of oxytocin if the contractions are becoming too intense. So I would like to end by summarizing all the points. Accelerations and normal variability are hallmarks of fetal health. This is somatic nervous system, variability is autonomic nervous system. Periods of decreased variability may represent fetal sleep, usually 40 minutes, sometimes 90 minutes. But sometimes the baby can sleep longer, provided you have seen a reactive segment before and the baby is sleeping for a longer time without deceleration, that is fine. And hypoxic fetus may have a normal baseline rate with reduced baseline variability. And in the presence of reduced variability, shallow decelerations are ominous in a non-reactive trace. This is the one which I mentioned, a long-standing hypoxic pattern. Abruption, cord prolapse, and scar rupture can give rise to acute hypoxia and should be suspected clinically, as I showed you one of the traces of the ruptured uterus. And hypoxia and acidosis may develop faster with an abnormal or pathological trace in patients with scanty meconium, growth restriction, infection, and so forth. So clinical picture is very crucial. And in preterm babies, if there is a pathological pattern, if we don't deliver them early, they can develop hyaline membrane disease and RDS, intraventricular hemorrhage, and cerebral palsy. So in a preterm, your threshold for delivery should be much earlier. And hypoxia can be worsened by oxytocin. Epidural not so much in early labor, but in late labor when the head is right into the pelvis and when she is bending down to have an epidural, the head goes and presses on the uterine vessel, and that can give rise to problems. And during labor, if decelerations are absent, asphyxia is unlikely because the uterus has to contract and compress the cord, which will give us variable decelerations or reduce the retroplacental pool of blood, which just get us late decelerations. If we don't see any decelerations and the trace shows tachycardia, reduced variability, it might be infection, it might be some abnormality in the fetus. So abnormal patterns may represent effects of drugs, fetal anomaly, infection, not only hypoxia, and if you examine clinically what is going on, you will be able to pick it up. So the points to remember is to interpret the CTG in relation to the clinical context. Recognize the pre-terminal trace immediately. Recognize acute compromise clinically. recognize the maternal heart rate, and machine can double the fetal heart rate or the maternal heart rate. So be careful, make sure there are two heart rates appearing, which one you are looking at. Do not disconnect the monitor 20 to 30 minutes before and obtain good quality recording. And errors in the use of oxytocin should be avoided. Thank you very much indeed.